All right. All right. Good afternoon, team. My name is Jennifer Kastner Thomas, and I'm the Code Director here at SENTA Partners. Thank you so much for taking the time out of your busy week to join us for today's Lunch and Learn. Today, we're going to take a closer look at medical decision making and go over the definitions that drive E&M levels and the medical necessity. Before we dive into the content, let's quickly review a few housekeeping items. This webinar is being recorded, so we're asking you to please mute your phones and computers to minimize background noise. To ensure we're able to cover all material within our scheduled time, we will take presentation-related questions at the end of the session. Also, the information presented today is current as of today and may change based on updates or clarifications released from CMS, the AMA, or any of our Medicare administrative contractors. If you have any questions at all, please don't hesitate to reach out to me. My email address is provided here on the slide. Okay, here's our agenda for today. First, we're going to look at AMA's policy regarding what conditions to count towards the number and complexity of problems addressed during an encounter. And then we'll discuss definitions related to each of these three elements of medical decision making, which includes the number and complexity of problems addressed, the amount and complexity of data to be reviewed and analyzed, and lastly, the risk of complications and or morbidity or mortality of patient management. First, let's look at the AMA stance on what conditions to count towards the E&M assessment and plan, also referred to the impression and plan within ModMed. The area highlighted in yellow is mainly what I want to bring your attention to. First, the sentence that states, symptoms may cluster around a specific diagnosis and each symptom is not necessarily a unique condition. This means that we should not be reporting signs and symptoms when a confirmed diagnosis has been established. This is further clarified in Chapter 18 of our ICD-10 manual. As you can see here on the screen, I added a snip from Chapter 18 that describes that signs and symptoms can be reported when a definitive diagnosis has not been established, and codes for signs and symptoms may be reported in addition to a related definitive diagnosis when the signs or symptoms is not routinely associated with that diagnosis. For example, we should not report nasal congestion and allergic rhinitis if the nasal congestion is related to the allergic rhinitis. In this example, only the allergic rhinitis should be documented within the impression and plan. Another example, ear fullness. We would not bill the symptom for ear fullness if the ear fullness is due to the cerumen impaction. Instead, we would only code the cerumen impaction. Next, you can see where comorbidities and underlying conditions only count if they are addressed and impact the data reviewed or the patient risk by the provider during that encounter. In other words, comorbidities and underlying conditions, they should not be reported in the impression and plan unless they directly impact the condition that you're addressing or if the condition is being monitored, evaluated, assessed, and treated. For example, counting deviated septum on each encounter would not be medically necessary unless the deviation is being treated or it's so significant that it's impacting the treatment of care. An auditor would question why it was medically necessary to counsel the patient on a deviated septum again when the patient presented with follow-up on allergic rhinitis. So it's not just the number of problems, but their complexity and impact that drive medical decision-making. Before we discuss the definitions, I want to bring your attention to this slide. This is the medical decision-making table, and this is what we use when determining each E&M level of service. For electronic health records like ModMed, the logic to assist providers with selecting the E&M level of service is based on this table. The medical decision-making table is mainly composed of the three last columns. The first one's the number of complexity of problems addressed. The second is the amount and complexity of data to be reviewed and analyzed. And lastly, the third column is the risk of complications and or morbidity or mortality of patient management. The medical decision-making table is the same for all settings. However, in this case, you will see that on this slide, this is a customized table where I included the code specific for the office setting as well as the office time, should the provider decide to use time. but the table itself is the same for all specialties, all settings. As you can see, as we go lower down the page, the scenarios reflect a higher level of care and decision-making based on the status of the presenting problem and any conditions that may impact the level of care. To determine the level of service, whether it's straightforward, low, moderate, or high, we must meet or exceed in at least 2 out of the 3 columns. For more information, in-depth instructions on how to select a level of service, please refer to the recorded presentation within the Cornerstone Learning module titled Evaluation and Management Coding, How to Select a Level of Service. This table outlines the number and complexity of problems addressed and how they contribute to determining the level of medical decision-making based on the definitions. Starting at the lowest level, at the top, minimal or low complexity, we're looking at problems that are self-limited or minor, such as conditions that follow a predictable course and are unlikely to impact long-term health. This level also includes stable chronic illnesses and uncomplicated acute conditions where the risk of morbidity is low and recovery is expected. As we move into the moderate complexity level, the picture becomes more involved. This includes chronic illnesses that are worsening, not well controlled, or have side effects from treatment. It also includes patients with multiple stable chronic conditions, new problems with uncertain prognosis, or acute illness that present with systemic symptoms, meaning they affect more than just one localized area. Additionally, more complex injuries that require broader evaluation or carry higher risk fall into this category. At the high complexity level, we're dealing with the most serious scenarios. These include severe exacerbations of chronic illnesses, significant side effects of treatment, or conditions that carry a high risk of morbidity and may require hospitalization. It also includes acute or chronic conditions that pose a threat to life or bodily function, such as major organ system compromise or rapidly progressing illness. The takeaway is that it's not just the number of problems, but their severity, stability, and associated risks that determine the overall level for this category. Providers must consider whether conditions are stable, worsening, or potentially life-threatening at the time the service is rendered when determining the appropriate level of service for this first column of the medical decision-making table. Again, keep in mind, this is one of the 3 columns. We must meet and or exceed the level of medical decision-making in 2 out of the 3 medical decision-making columns. A few other things I want to point out in this slide before we move on to the next. In yellow, you could see chronic condition. This is for one stable chronic condition. AMA's definition of a chronic condition is a condition that has expected duration of at least a year or until the death of the patient. Also, these chronic conditions must be conditions that are being treated by the provider. Treating a condition means that we're monitoring, evaluating, assessing, and treating it. So chronic conditions being monitored and treated by the PCP should not be counted towards your medical decision-making unless the provider is doing something with a condition or it's directly impacting the condition that the provider is treating. If we have 2 stable chronic conditions, then this is a moderate. And then a chronic condition with exacerbation, this is also moderate. When a chronic condition is not at goal and changes are made to the treatment plan, then this is considered an exacerbation. And then the last one for a chronic condition with severe exacerbation. This is a high, and we're not allowed to make clinical judgments as coders, so it's recommended that providers document when they clinically feel that the patient is having a severe exacerbation of a chronic condition. So that covers the chronic conditions. Now I want to talk quickly about acute conditions. So acute uncomplicated illness or injury, this is a low. An acute illness with systemic symptoms. Now let's read this definition. Acute illness with systemic symptoms is a moderate, and so it says an illness that causes systemic symptoms and has a high risk of morbidity without treatment. For systemic general symptoms such as fever, body aches, or fatigue in a minor illness that may be treated to alleviate symptoms, shorten the course of the illness, or to prevent complications, see the definition of self-limited or minor or acute uncomplicated. So again, the takeaway here is if the systemic symptoms the provider is counting is related to fever, body ache, or fatigue, then those are not consistent with systemic symptoms based on the AMA definition. That defaults more toward acute uncomplicated, or like it mentions, self-limited or minor. For us to get credit for acute illness with systemic symptoms, it must impact another organ system. Example, maybe the difference between otitis media and then otitis media with maybe cellulitis. They have enlarged lymph nodes with a cellulitis. They may have to drain an abscess or something. That's an example of an acute illness with systemic symptoms. The lymph nodes, enlargements, that's an example. So again, the takeaway with acute illnesses, if the symptoms that are being described is for fever, body ache, or fatigue, then that does not constitute acute illness with systemic symptoms. Instead, that's more likely an acute uncomplicated condition. Also under acute illness, we have an acute illness with severe exacerbation. So if there's, again, we're not able as coders to make a clinical judgment. So if a provider feels like they're in a severe exacerbation, then I highly recommend that they document the word severe to prevent the scrutiny from an outside auditor. All right, so we just covered the first column titled Number of Complexity of Problems Addressed. Now we're going to put our attentions toward this second column, which represents amount and/or complexity of data to be reviewed and analyzed. This section is quantitative, and as you can see, that we'll need to quantify elements within Category 1, Category 2, and Category 3. Each level has a particular requirements. Here you can see where for Category 1, we must have a combination of 3 from the list. And I'm going to go over this list, and then on the next slide, I'll dive more into what some of these definitions mean. For Category 1, the list shows reviewing prior external notes from each unique source, review of the results from each unique test, ordering of each unique test, and lastly, assessment requiring independent historian. Before I move further, I do want to add that we cannot get credit for ordering and reviewing the same test. When a provider orders a test, it's inferred that they will also give the results to that test that they ordered. So we can't get credit for ordering and reviewing for the same test. Moving on to Category 2, which represents independent interpretation of test. And then we have Category 3, discussion of management of test interpretation. Again, we'll go over those definitions more on the next slide. In summary, as you can see, each level of service has different requirements, all which can have an impact on the level of service. All right, so here are the definitions that I wanted to cover related to the data section for the amount and complexity of data that is reviewed and analyzed. First, when we talk about test, we're referring to imaging, lab studies, or other diagnostic data. It's important to note that a lab panel, like a metabolic panel, is counted as a single test, even if it includes multiple values. The difference between a single or multiple test is defined in accordance with the CPT code set. If it has a unique CPT code, then you go with that. So as it mentioned, the metabolic panel 80047, there's multiple components within that, but since there's a CPT code specific to a metabolic panel, then we would only bill that one. We would get credit for one test. Next, when we refer to external data, this refers to information coming from outside your practice, and this can include records, test results, or communications from other qualified healthcare professionals or physicians or a healthcare facility. So when I'm talking about that, it goes into, review of prior external notes. I want to emphasize this doesn't mean a provider could go back and look at their own previous notes. It has to be from another source. It has to be external, and it can't be a partner's note from someone else within the practice. It has to be, from external a provider. So PCP, another specialist, whatever it may be. Next, external qualified physician or qualified healthcare professional. This is someone who's not in your group or is in a different specialty. This distinction is important because reviewing their information adds to the complexity of data. And then independent historian is another key concept. This is someone like a parent, guardian, or a caregiver who provides patient history when the patient cannot give a complete or reliable history themselves, or when additional confirmation is needed. The medical record must reflect the level of information for credit. Simply stating mom is present doesn't reflect that history was obtained from mom. Just like with anything in medicine, if it wasn't documented, it wasn't performed. And then this next one is a big one, independent interpretation. This refers to when a provider personally interprets a test, such as an X-ray, EKG, or a CAT scan, separately from the official report. This only counts if the provider is not also billing for the interpretation. For example, if we're billing for the global CPT code for a CAT scan, then we cannot get credit for independent interpretation in the E&M, as this is considered double dipping because a portion of the global payment for the CT scan includes the interpretation. The same goes for audiology tests. If the audiologist within the group is billing for the audiology services, your group is being paid for the audiology code. Counting the audiology interpretation into the E&M decision-making is considered double dipping. Providers within the same organization are an extension of each other and are not considered external. And then finally, the last thing listed here is appropriate sources. This comes into play during discussion of management, and this includes professionals involved in the patient care who are not healthcare providers, such as case managers, teachers, or legal representatives. But it does not include family members or informal caregivers. Overall, these definitions help clarify what counts toward data reviewed and how it contributes to the overall level of medical decision-making. This last set of definitions that we're going to cover relate to the last column of the medical decision-making table called risk of complications and or morbidity or mortality of patient management. The AMA didn't provide examples for minimal or low, but minimal may include follow-up if the symptoms return, or rest and elevation, hot compresses, etc. Low includes notations of follow-up appointments, like follow-up in 3 months for, audiology. There's some follow-up occurring for identified conditions, referrals to another specialist, DME, over-the-counter medications. Now, moving on to moderate. Examples of moderate include prescription drug management, decision regarding minor procedure with patient risk factors, decision regarding major surgery without risk factors, or diagnosis significantly limited by social determinants of health. With high, you could see the risk includes major surgery with risk factors. So if that, usually if a major surgery is being done and they have risk factors, a lot of times they'll have to get clearance from cardiology or something. That's an indication that maybe that patient's at high risk if they have to get clearance before they can have surgery. Also, drug therapy requiring intensive monitoring for toxicity and decision regarding hospitalization, among others. I do recommend just becoming familiar with the examples within this AMA table. All right, so now we'll move on to the definitions related to the last table, the last column for the risk of complications, morbidity, or mortality within the medical decision-making. First, let's talk about risk. This refers to the probability and potential consequences of an event. In coding and documentation, risk is assessed based on the clinical situation and the potential outcome if the condition is treated appropriately. It can range from minimal to high, depending on the severity of possible complications. Next, we have morbidity, which describes a state of illness or functional impairment that significantly impacts a patient's quality of life or daily functioning and may involve long-term or permanent effects. Also listed here, we have social determinants of health, which are economic or environmental factors that influence patient outcomes. Examples include food insecurity, unstable housing, maybe lack of insurance that they're not able to get their medication, or another one, environmental factors. Maybe the patient has severe asthma and their home is infested with mold. that would be an environmental exposure that is affecting the condition, the asthma that the physician is trying to treat and having complications because of the exposure to the mold. So that was social determinants of health was a rather new thing that was added a few years ago. But now, you could get moderate risk as long as it's truly affecting the patient's condition for what's being treated. And the documentation clearly says that. It can't just say patient has problems with social determinants of health. It has to lay out and be clear, documented of what those barriers are. Another important concept is the prescription drug management, which refers to a provider actively managing medications, such as initiating, adjusting, or discontinuing prescriptions based on the patient's clinical status. Of note, over-the-counter medications are not supportive of prescription drug management. Instead, over-the-counter medicines are considered low on the table of risk. Prescription drug management requires the prescriptive authority, and if the drug is available over the counter and via prescription, then it does not require prescriptive authority. Also, the documentation must support prescription drug management by stating the drug name, dose, and instructions. Simply listing continued medications is not supportive of prescription drug management from CMS nor many of the payers. Finally, the last thing we have listed here is drug therapy requiring intensive monitoring for toxicity. And this applies when a medication has the potential for serious harm and requires ongoing monitoring, such as lab tests or imaging, or detect adverse effects, rather than simply assess the therapeutic benefits. Examples of these drugs include lithium and chemotherapy. Together, these definitions help determine the overall level of risk within medical decision-making, which directly impacts the E&M level of service. On this slide, it's just a visual of, for those that are not familiar with E&M coding, of how it all ties together. How I mentioned earlier, we must have 2 out of the 3 columns here. So this displays that we got 2 out of 3 columns, therefore, out in the moderate. So this would support a moderate if the documentation ties to all of this. So moderate for a chronic illness with mild exacerbation, progression, or side effects. Very few lab tests, but then prescription drug management. So we have 2 out of 3 and moderate, therefore moderate can be applied. Let's say this first one really, and it's not showing here, a high medical decision making. Let's say we have a high in the number of complexity problems addressed. Then that case, it would be a moderate because we have to meet or exceed 2 out of the 3 columns. So it would not be supportive of a high overall medical decision making because I only have 1 column that would be high, 1 column that satisfied a high level. So yeah, this is just a visual of how that all turns out. It ties together at the end for those that are not familiar with how this process goes, and mainly to show that it takes more than just 1 column. A lot of providers I've worked with, they think, well, this patient was, I mentioned we could have a high on the number of complexity of problems addressed. They were really sick. They were having an asthma attack and all that stuff. So they could be high here, but unless the data also supports high or the risk and it meets any of the criteria for high, then it's not going to be a high. So again, 2 of the 3 is required when it comes to tying it all together. This slide reflects some references that you could go to check out related to the information that I covered today during our presentation. All right, and that concludes today's topic. I'm going to stop recording and then I'm going to open the floor up to any questions related to the information that we covered today. If you have any questions after today's session, please feel free to reach out to me at jennifer.kastner@sentapartners.com.